Welcome to ASM Live at ICAAC. I'm Michael Schmidt. I'm one of the moderators of This Week in Microbiology, which you'll be able to catch live here in a few hours. But in the meantime, we have a special treat here at the InterScience Conference on Antimicrobial Agents and Chemotherapy that's taking place all week here in Denver. This afternoon we have with us Dr. Susanna Esposito from the University of Milan at the Hospital Polyclinical, and we also have Dr. David Murdoch from our good friends in New Zealand, who's going to share, both of them are going to share with us some really exciting headline news type things about the role of vitamin D, and Dr. Esposito is going to talk about her most recent study showing the role of vitamin D in preventing recurrent otitis media, those nasty ear infections that we worry about with our little toddlers as they tug at their ears. So welcome, and thank you for taking time out of the very hectic and busy meeting, and we're honored to have both of you here. Hello.
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 So we're just going to have a conversation,
Yes.
and we have reporters in our midst here today who will ask us questions. We're also streaming live on the internet, and we have the Twitterverse, and if they have questions, all they need to do is post their question at the hashtag ICAAC, and we'll be able to take care of their questions in real time. And so, Dr. Esposito, why don't you tell us the beginning of the role of vitamin D and infections, and then we'll pass it over to Dr. Murdoch, and the two of you will have a little conversation about something so simple as vitamin D and infections.
Yes. So vitamin D has an important role in the interaction with the immune system. And for children, this is an important issue because we know very well that children in the first years of life have frequent recurrent respiratory tract infections. That means that at the end, during winter months, every month they have otitis, pharyngitis, or only otitis, but I mean for around 4 to 5 times per year. This is an important problem because in the first 3 years of life, almost all children have at least one episode of acute otitis media, and around 20 to 30% of them have recurrent episodes. So starting from the role of vitamin D in conditioning the susceptibility to infections and also the severity of infections, we have decided to evaluate whether the supplementation of children older than 1 year, so I mean from 1 to 5 years, that is the period of life with the highest risk of recurrent respiratory tract infection. So we would like to evaluate whether this supplementation can reduce respiratory recurrences, and in this specific case, acute otitis media.
So you're just asking a simple question. If you give a vitamin supplement to these toddlers between 1 and 5, will they have another episode of an ear infection? Something really simple, something really inexpensive, I would imagine, and something life-altering for the parents who are taking care of these kids.
Yes. First of all, I have also to say that we have collected preliminary data in these children on the basal level of vitamin D.
So you know what the concentration is in their system?
Yes. And so in patients that we follow in our clinical practice, we found very low level of vitamin D, below 20 nanogram per ml. That is a level that is considered a marker of insufficiency. So
in Milan is not Northern Europe. You get sun in Milan.
I think that Milano is North Europe at the end, but because it's not really south. But however, the point in we observe these low levels, and so we say, yes, first of all, we have to check these levels because it is very important to demonstrate the efficacy, but also to demonstrate that this efficacy is related to a specific level.
The cause and effect.
Yes, and for this reason, we studied the cause and effect. So we studied the level at baseline. We randomized our patients to receive vitamin D 1,000 units per day for 4 months, so every day for 4 months before going to sleep. And then we look at the level at the end of this supplementation, and we monitor every month and with weekly telephone call the recurrent episodes of acute otitis media.
So all the parents had to do is to supply a simple gel tab to their
Yes.
child once each day.
Yes.
And they had no troubles giving the kids. The kids well tolerated taking the pill, so that it's not as, you know, the size of a small car that they have to eat.
No, yes. It was very easy because you know that the possibilities for preventing recurrent acute otitis media are at the end the use of antibiotic prophylaxis that at the moment is not indicated for the risk of antibiotic resistance. Then also the tubes that in Europe are not largely used, but in the United States they are largely used.
We love tubes in the United States. Small children seem to have more appliances being added to their heads to prevent recurrent otitis media. I mean, pediatricians, and the only thing that the microbe loves better than people are plastic, and so you, of course, worry about these conditions.
Yes, it is at the end an invasive procedure. And then, of course, influenza vaccination and pneumococcal vaccination work. This is true, but not totally. And so for this reason, our children were largely vaccinated against pneumococcus, more than 80%, and they were all vaccinated against influenza. But despite these preventive approaches that we already use since several years, we think that something more was needed, and for this reason we added vitamin D, starting from the data coming from the literature showing its effect, in the interaction with the immune system, and data showing that a large part of pediatric population with recurrent infections have low level of vitamin D. Then we have our data collected in clinical practice that confirm this position. And so we think that this group of evidence was quite strong for organizing a prospective randomized trial. And for this reason, at the end, we perform in the last winter season this kind of study.
So, Dr. Murdoch, you have a variation on this theme. Rather than looking at recurrent ear infections, you're looking at the other scourge of the upper respiratory rhinoviruses, correct?
Well, the common cold.
The common cold.
Some of which is
So all
caused
of
by
the above.
rhinoviruses. Exactly. Our question was again very simple, but we were focused on adults, and our trial was to see whether vitamin D would prevent episodes of the common cold.
So we have a
respiratory
pediatric
infection.
population with Dr. Esposito's work, and we have an adult population with your work. So we really have a perfect world here now. We can compare and contrast. So what did you learn?
Well, we had all healthy adults. A number of volunteers, they're healthy adults. We gave half of them vitamin D for 18 months. So we followed them for 18 months over, over 2 winters. Yeah, exactly. And these were monthly doses of vitamin D, so they're relatively high doses, once per month. We were measuring the frequency of colds, how severe the colds were, the time off work due to colds. And I'm afraid we disappointed many people because we found there was absolutely no effect.
Really?
Yes. So resoundingly no effect, no difference at all between the two groups.
Interesting. So what did you find, Dr. Esposito, in your group?
Yes, our results clearly shown in a population of 116 children that the supplementation with vitamin D increased the serum level, of course, of vitamin D, and this increase is significantly associated with a reduction in the total number of acute otitis media episodes. However, it was very interesting because we observed that the positive effect is significant in the group of children with recurrent acute otitis media, of course, so not the healthy population, but those that already have recurrences, and in avoiding the risk of uncomplicated episodes of acute otitis media. What does it mean? That the efficacy against membrane perforation, so the problem of recurrences in children that frequently have this kind of perforation, is quite limited. So we try to hypothesize some ideas for why there are some children without perforation that have the major benefit and others with perforation in which the significant benefit is not observed. Our hypothesis is that probably in the population with perforation, streptopyogenes, that usually is the main pathogen, is the one that causes the disease and is the one that produces some bacterial factors that cannot really permit to observe the benefit that we observed in the population without perforation. Then the other important issue is that the benefit that we observed is related to the level that we reach in the blood. So the level of
vitamin D.
Yes, the level of 30, so the concentration in the serum of 30 nanogram per ml is the concentration that permits to avoid recurrent episodes of otitis. Yes, and this is an important information because in clinical practice, what does it mean? First of all, that of course, if we have a child with recurrent episodes of acute otitis media, we can check to the level of vitamin D in his serum, and in presence of level below 30, we can consider the use of vitamin D, because this is an important point. Then, of course, probably some more studies are needed in order to identify whether in healthy children, in some of the healthy children, you can reduce the risk of acute otitis media, generally, not the risk of recurrences, but the risk of acute otitis media, in relation to this serum level. So probably some more studies are needed in order to evaluate whether we can even increase the population that can have benefit from vitamin D. But of course, I think that the clear demonstration of our study are that children with recurrent episodes have low level of vitamin D. And the increase in the level over 30 nanogram per ml is associated with a significant reduction in the number of recurrences.
So let's contrast your data, and Dr. Murdoch, you may or may not have asked this question in your study. Did you look at the circulating levels of vitamin D in your cohorts?
We did. And our baseline levels were probably not as low as we thought they would be in our population. They weren't overly high, but the baseline certainly wasn't low, and that may be an important factor in our results. The fact we may have seen an effect if we'd studied a much more deficient population. So that's an unanswered question, but I'm confident from our results that healthy adults with good vitamin D levels probably don't need to be supplemented for prevention of colds. And there may be other reasons.
This is true. So, looking at this problem holistically, why do you suspect children had an effect with the vitamin D supplementation? Do you think that they are truly deficient and they just haven't adapted their livers properly for making vitamin D? Is it simply a function of surface area of their skin not being able to convert?
You know, this is a real open question, but of course, the data demonstrate that probably both factors work together. So there is an insufficiency. This is an important issue due to several reasons, even air pollution and some changes in the kind of life of our children. But of course, the in vitro studies support the interaction that vitamin D had with several different pathogens involved in acute otitis media, and also in the production of cytokines or other kind of inflammatory markers. And so in this way, at the end, vitamin D may be able to reduce the number of recurrent episodes.
So when do you think, you know, this is really an unfair question, but I'm going to ask it anyway. When do you think you have the transition between the effect that you see in the toddler, the 1 to 5-year-old, and the adult population? It's just merely a stature issue, how big the individual is in terms of converting vitamin D?
Well, I think it is to do with the vitamin D levels. So, I mean, there are adult populations that are deficient, and we see effects in those groups. So I think that's probably the major factor.
So what's next?
I think that next it is very important to evaluate the role of vitamin D in the risk of infection, even in healthy children in the pediatric population, because if it could represent a supplementation that is very cheap and totally safe. This is another important issue because we have no safety issues in our study. The minor adverse events that were reported were exactly the same reported in 5% of those that received the placebo, and no serious adverse events. So I think that this is a strategy that can really permit to reduce the number of infection in the pediatric population. And so I think that the next is, first of all, to study its role in prevention of infection overall, I mean mainly respiratory, of the pediatric population. And then another important point that we have already evaluated is the interaction between vitamin D and the immune response to vaccination. Because it can also be a system that increases the immune response to vaccination, especially in young children. So I think that there are these open points, and I think that some more studies should be done because it is a very easy strategy that can have an important benefit.
Dr. Murdoch, what's next for you?
Focusing on populations that have a low, are perhaps more unhealthy group that have a low vitamin D level. So we're focusing on adults with pneumonia as well, who we know have low levels, and that may or may not be related. And then there are obviously options for children as well.
Do you think it may be an issue also in the otitis media cases? It's principally a bacterial infection.
Yes.
And you effectively were measuring a viral infection. Do you think that may play some role in the differences that we've seen between the two populations?
We don't really know, actually, and certainly there's evidence in children for respiratory infections in groups that are deficient for pneumonia and respiratory and upper respiratory infections to actually have a benefit from vitamin D supplementation. So I'm not sure it's specific to the type of organism.
Yes.
We actually don't know enough about it.
I agree with this position. I think that there are also data very interesting coming from the developing world showing that in children with malnutrition or HIV and severe infection like pneumonia, the supplementation with vitamin D improved the outcome even in treatment. So this is another important point to consider the role that it can have for therapy, not only for prevention, so associated with other drugs, I mean with antibiotics, but for reducing the duration of illness in severe infections.
Okay, do we have any questions from the audience? Yes, sir. Please use the microphone and state your name. Just the reason we're using the microphone is so the Twitterverse can actually hear us.
Thank you very much. My name's John Sheezer, and I'm covering this meeting for the Medical Post of Canada. I wondered, of the 116 children in your study, what percentage were they below normal range? Were they all 20 or 30% below range on vitamin D supplement? And how much did you increase it when you saw the benefit?
No. The number of those with low levels were around 80%, so it was a huge number of children. The population was randomized 1-to-1 in receiving vitamin D or placebo. So at the end there were 58 children per group. And at the beginning, the two populations were exactly the same, so their characteristics were similar, and also the level of vitamin D was similar. The level was, 80% below 30, but at the end, at the beginning, because the study started in November, so after summer holidays finish usually in September. But in October, children are often outside. So their mean level was around 20 nanogram per ml. That is, however, a level lower than that recommended. Then, with the use of the vitamin, there was a significant increase, and the population that was treated moved from around 20 to more than 30 nanogram per ml. Only 2 children of the 58 treated did not reach this acceptable level. Regarding the placebo, it was interesting because, of course, the mean level at the baseline was 21, but at the end of the 4 months, probably because it was winter and they remained inside, the level was below 20. The mean level was 18, and none of them had levels higher than 30. So I think that the point of the increase was relevant because the increase was from 21 to more than 30 in almost all the children. And we have no safety issue. Also the problem of safety is important because there is a huge discussion on the optimal dosage of vitamin D. There was a previous study that considered 600 units per day, but with this amount, the level that is reached in the majority of the population is between 20 and 30, so not more than 30. For this reason, we increased the level. But however, we know that possible adverse events can be observed with level higher than 2,500 per day, so higher than that, largely higher than that recommended in our study. And honestly, we really have good results in terms of safety.
Just to clarify then, both arms, the placebo arm and the treatment arm, were matched identical in terms of their vitamin D levels going into the study. It started at baseline,
yes.
Is that correct? And they averaged between 18 to 30? Or do you have a median of what their vitamin D levels were in each
The median
arm?
was around 21.
The median was 21.
In both the groups, yes.
And what are the ranges? What's high, what's low, and what are the parameters?
The range was from, in some cases, starting from 12, so very low,
yes.
and up to 25.
Okay, so all of them ranged from 12 to 25, and the median was 21.
Yes, yes.
And anything below 30 is suboptimal. It's
Yes.
considered low.
Yes, yes.
And in all but 2, you raised it to above 30.
Yes.
Thank you so much.
Thank you for the questions.
Thank you for the question. Any other questions from the audience? Jim, do we have anything from our friends in the Twitter sphere? Nothing yet. Well, do you folks want to add anything else to our discussion here this afternoon?
I think just to really emphasize from our perspective that we really think there should be a shift toward the population. We studied a healthy population, and that's where a lot of the media interest and public interest should generally supplement to prevent the cold. And I think what we've shown is that you don't if you're healthy and you're for preventing the cold. That's right. So the focus for further research should really be on different groups that are deficient in one way or the other.
So what is the average vitamin D level in your New Zealand population?
Well, we have some of the highest sunshine hours in the world and the highest skin cancer rates in the world. But surprisingly, we have a lot of vitamin D insufficiency, and that's probably because we have very strong messages from our Cancer Society to cover up. So children in the summer go out with swimming costumes down their arms and down their legs to protect, and kids can't go to school without hats. So there's been a very strong message. We don't have any fortification of our food, and you can't buy over-the-counter vitamin D that's of a high dose. So probably for all those reasons, we actually have a surprisingly high amount of vitamin D insufficiency, and particularly in our Polynesian populations.
Well, thank you. Well, we have been chatting with Dr. David Murdoch and Dr. Susanna Esposito from the University of New Zealand.
Otago.
Oh, Otago, I'm sorry.
That's right.
In New Zealand. I got the sub right. And Dr. Esposito is from the University of Milan. And we thank you for joining us today on ASM Live at ICAAC. And thank you very much for your time. Enjoy the rest of the meeting.
Thank you.
Explore the fundamental role of microbes in the natural history of our planet with Microbes in Evolution, the world that Darwin never saw. Available at estore.asm.org.